Good afternoon, everyone. It is so good to have so many of you here for this important conversation. I hope all of you continue to be safe and well. I am Eve Lee, Executive Director of AOPA. About a month ago, we issued a survey to the AOPA membership regarding the impact you were facing in response to COVID-19. One topic that came back was telehealth. And during this town hall, we will be discussing the results of that survey and the steps AOPA has taken to address the survey responses to date. We will then talk about how telehealth works in practice and in the importance of telehealth in the continuum of care. Most importantly, however, we will then open it up to Q&A and discussion on AOPA's proposed telehealth strategy to ensure it benefits you and your patients. Throughout this town hall, we will be launching polls. Polls in this platform use pop-up windows. If you have pop-up windows disabled in your security settings, we encourage you to double check that because you may not be able to answer the polls live. Please use the question tab in your panel to submit all questions for our speakers. We are going to do our best to answer as many of them as we possibly can during this live broadcast. We will also work to follow up with any questions that we are not able to get to during the live broadcast. To help facilitate these conversations, I am joined by a few of my colleagues. Jill McTurnan is AOPA's Director of Coding and Reimbursement Services, Education and Programming. Ashley White is AOPA's Director of Strategic Alliances. We're joined by Kathleen DeLawrence, Chief Operating Officer at Ability Prosthetics and Orthotics. And we're also joined by Dr. Pratik Grover, Medical Director at the Rehabilitation Institute of St. Louis. We really appreciate you joining us again this afternoon. And for now, I will turn it over to Joe.
Thanks, Eve, and thanks everybody for joining us today. It's so important to have this open communication going back and forth both ways from AOPA to our members, and then having that feedback and that information coming back in. So my part of the presentation today really talks a little bit about what AOPA has done to date as far as relief that we have been able to discuss with CMS to help get your businesses operating and continue to operate. Some of those relate to telehealth, some of those are more basic in nature. But quickly going back to the survey that Eve talked about earlier, we do want to thank everybody for participating in that valuable survey. We did have over 100 patient care facilities respond to our survey with a slightly fewer number of manufacturer and supplier members, but still a very good number of respondents in that survey. And it gave us a tremendous amount of information. Now, Ashley's going to take you through some more of the specific telehealth survey responses, but I just wanted to go over just a couple of things that we learned as a result of the survey and how the COVID-19 public health emergency is truly impacting all of our members here at AOPA. So we quickly learned from the survey results that almost nobody is able to continue to operate at full and normal capacity during this emergency. Less than 15% of our patient care facility respondents said that they were operating at full response or at full capacity. Now, the other side of that coin, less than 5% of people who responded said that they had actually just ceased operations temporarily. So people are doing their best to make sure that they are still able to meet the needs of the public and still provide service to their patients, and that is so valuable and so important. What we also learned is that, unfortunately, that both on the supplier side and the patient care facility side, the reality of this public health emergency is that because of reduced capacity, because of reduced volume, that folks have unfortunately had to make very hard decisions about potentially reducing clinical staff, administrative staff, hours, etc. And those are very, very hard business decisions to make, whether they are furloughs, whether they are layoffs, however they are structured. So without going into all of the numbers, the survey is very, very valuable, and there's more information available in the survey that my co-presenters are going to discuss in the remainder of today's presentation. But I'm gonna transition now and move into some of the things that AOPA has been able to accomplish, working very closely with the DME MACs, with the CMS, to try and get whatever relief we can. First and foremost, it is so important to remember that there is not a question, not at all, that your business is essential. One of the things that almost every state put in place very quickly into this public health emergency was a stay-at-home order, which essentially shut down any what were considered non-essential businesses. AOPA was able to confirm very early on and able to review the different state orders and the different governor's orders, and we did not find a single instance in any state where that stay-at-home order would prevent either a patient care facility or a supplier business from being able to continue to operate and continue to serve the public during the public health emergency. So that was a question we had constantly at the very beginning of this situation was, can I continue to keep my doors open if I so choose? And the answer to that is yes. Obviously, people had to make individual decisions about how to best and how to most safely operate their businesses. But then we turned very quickly to looking for relief. And one of the things that very quickly rose to the forefront of that question was telehealth. How is telehealth going to factor into the new world order that has come as a result of the public health emergency? And there were a lot of questions like, were we going to be able to rely on documentation that was obtained through telehealth visits? Was O&P as a profession going to be able to use telehealth? If we could, how extensively could we use telehealth to take care of our patients? And that very quickly became an area where we very, very rapidly understood there was no simple yes or no answer to that question. There is a lot of ins and outs and a lot of nuances that occur in that question. So one of the things that was immediately up in the air had to do with diabetic shoes. And I deal with this first, or I talk about this first, because this is the most recent development that we have had. In the beginning of the public health emergency, there was reluctance on the part of the Medicare contractors to acknowledge the role of telehealth in the provision of diabetic shoes, primarily with regards to whether or not certifying physicians, these are the MDs or the DOs that are managing the patient's systemic diabetic condition, whether they could use appropriate telehealth to certify the medical need for diabetic shoes. And initially we were told that that was a statutory requirement, that there was a face-to-face requirement in statute, and therefore that could not be waived or forgiven or achieved through telehealth. Well, Medicare came out with two what they called IFCs, which stands for interim final rule with comment periods, in which they significantly waived and reduced the burden on the face-to-face requirements in any what are called national coverage decisions or local coverage determinations, which are the Medicare policies that govern coverage of Medicare services. And that opened the door specifically for diabetic shoes, and the fact that anything that any NCD or LCD that required a face-to-face visit with a physician could now, under the IFC, be achieved and be considered compliant through the use of telehealth services. And we were able to, AOPA was able to confirm just last week in a series of advisory council meetings with the DME MACs that the IFC, the interim final rule with comment period, actually did confirm that this did include physician telehealth visits for the purposes of certifying the medical need for diabetic shoes. So in addition to that, that has now carried over, and that same waiver through the interim final rules has now carried over to other areas where a face-to-face visit would be implied. So, for example, in the knee orthosis policy for knee braces, while it is not specifically stated, one of the requirements for coverage and for medical need is a objective description of what is called joint laxity, which literally could only be, in the past, could only be achieved through a face-to-face visit because it had to be an objective description, meaning that the physician who was certifying the medical need for that knee orthosis had to personally observe that knee laxity, that joint laxity, in order for that knee brace to be covered. Again, this is now able to be accomplished through telehealth. It still has to be an objective description. There still has to be documentation of that description. However, if the physician can achieve that observation through a telehealth visit, that now meets that requirement of that policy during and for the remainder of the public health emergency. So those are just some of the factors that have come into play, some of the regulatory flexibility that CMS and the DME MACs have been extremely willing to work with provider groups, willing to put the interests of patients first and foremost, and willing to make sure that patients continue to have access to medically necessary care, especially orthotic and prosthetic care, without necessarily having to put themselves at risk of exposure to contracting the virus, simply so that they could achieve a face-to-face visit that could easily be accomplished through telehealth. Now, the natural question that comes next is, how does this relate to O&P and orthotics and prosthetics? And in that situation, there's a little bit of a larger issue at play, in that the interim final rules did allow for regulatory flexibility in the local coverage determination requirements and the policy article requirements and the national coverage determination requirements for face-to-face interaction, but they do not address and they do not relieve requirements in other regulatory documents. And one of those regulatory documents is the DMEPOS quality standards, which do essentially require some face-to-face interaction in the coordination of the actual delivery of certain custom-fitted and custom-fabricated orthoses and prostheses. Again, this is a situation where telehealth, it's yet to be seen how telehealth may play a role in the future in the delivery of orthotics and prosthetics. But it's important to remember that one of the things that AOPA and our sister organizations in the Alliance, and as well as other organizations that we work closely with, we have for many, many years, we have been a promoter of the DMEPOS quality standards. In fact, part of the standards themselves were partially written by the O&P profession. And one of the things that we have been, the profession has long been a proponent of, is the need to ensure the proper fit of custom fit and especially custom fabricated devices. And sometimes, frankly, this does require some personal interaction where that fitting has to be confirmed and has to be viewed. It has to be accomplished, and sometimes it does necessitate some face-to-face interaction. The idea is to work with the regulatory agencies to develop telehealth opportunities where they are appropriate to establish the medical need and the appropriate fit and fabrication of custom fit, custom fabricated, especially orthotic and prosthetic devices. So with that, I will open the floor to any questions that I am able to answer, and then we'll pass it on to our next speaker. Ashley, if you want to come in and facilitate, that'd be awesome.
Yeah, so we have some questions for you, Joe. We'll go ahead and ask those in order as we're receiving them. We have some pre-submitted questions as well. First question, is it acceptable to perform an initial evaluation for a prosthetic patient via telehealth to get the paperwork processes started?
So I would say in that situation, the requirements that are currently in place from a regulatory standpoint are really focused on the delivery and the end result of the prosthesis or the orthosis. So I do not see any administrative or regulatory hurdle that would prevent folks from at least beginning the process through a telephone interview, through an audio and a video conference, a telehealth visit, to gather just basic graphic, typical intake information. I am not aware, and I don't believe there are any regulatory hurdles to using telehealth and using telephone conversation to facilitate that.
Similar to that question, to qualify for the Medicare face-to-face visit. So this is the framework of that question as a qualifier. Is it required to use both audio and video?
So during the public health emergency, actually, that's one of the things that CMS has been really flexible on relaxing. While telehealth has always been an acceptable method of accomplishing healthcare, in the past, it's been extremely restrictive, meaning that patients would have to go to a approved telehealth center, where there were certain restrictions in place that assured security, that assured only that there was an adequate video link, there was an adequate audio link. The rules have changed, at least temporarily, and pretty much any form of communication is now fairly acceptable to achieve telehealth and subsequent requirements of face-to-face visits through telehealth, at least during the health emergency.
Are virtual deliveries of OTS knee braces acceptable if well documented?
So I would say that for OTS, and I want to be very specific here that we're talking about OTS delivery, there has really never been a face-to-face requirement in order to facilitate that delivery. What it is said as part of the supplier standards is that suppliers are responsible to ensure that devices they provide fit properly and are appropriate for the patient's medical condition. As far as a mandatory face-to-face visit, that is inherent in the quality standards for custom fitted and custom fabricated devices. But for designated OTS devices, as long as you are following proper protocols and giving the patient the opportunity to express concern about the fit of that device, there should not be a hurdle. Now, whether that's the best practice or not, I think is up to the individual practice. Whether that can be achieved through a virtual visit with the patient where the practitioner is observing the fit of that device, for OTS only, there's no specific requirement that I am aware of that would prevent that.
A question for clarification. For O&P devices, the telehealth video visit will work, but the notes still need to document the objective findings required in the LCDs, like knee laxity, weakness or deformity in the ankle, etc.
That is a really, really, really good question, and it's very, very accurate. Yes, that is correct. So the requirements for coverage and the requirements for LCDs and NCDs are not changing as a result of the PHE in general. How that information is documented is what is changing. So as long as the physician is documenting the joint laxity in the case of the knee orthosis per se, that is still a requirement of the policy. How they are obtaining that information and how they are documenting that is now allowed by telehealth, and is now allowed by any form of telehealth that Medicare acknowledges during the public health emergency, but it does not eliminate the requirement that documentation exists. That's correct.
Great. So I don't see any additional questions specific to the topics that you've covered, Joe, but we will come back if we have any additional ones. And now we will open it up and have Kathleen DeLawrence join us. And we're going to launch a live poll here. Are you currently utilizing telehealth to provide care to your patients? Looks like we have some poll responses coming in. Well, this is great. Looks like people are still voting, so we'll give a minute or so here. Wow. With 44% voting, it looks like 62% of you all attending the telehealth town hall today are utilizing telehealth to provide care to your patients. So that is significantly higher than the survey that Joe referenced earlier that we sent out to AOPA membership towards the beginning of the COVID-19 crisis. It was less than 45% that reported that they were using any type of telehealth, whether that is peer-to-peer or patient care specifically. So an interesting change there. It looks like more people are adopting telehealth into their practice. And with that, I'd love for Kathleen to share some of those ways that that we're implementing telehealth in O&P practice.
Thank you, Ashley, and thank you for the opportunity to talk on the topic and at least give you a quick overview of where we are at this time with how we're looking at telehealth, telemedicine, and beginning to implement it within our practice. And the background that Joe provided was actually really helpful. I was taking a lot of notes about all the guidelines. But I think one of the things that we at Ability have made a distinction on is the difference between telehealth and telemedicine, recognizing that telehealth is acknowledged as the use of digital technologies to deliver medical care, health education, public health services by connecting multiple people in separate locations and over a broad definition of technology-enabled services, right? And that's sort of a direct quote from the Startup and Resource Guide from back in October of 2014, which I'm sure is in the process of being rewritten. And it refers to remote non-clinical services, administrative meetings, continuing ed, clinical services. But in specific to telemedicine, it goes on to say that the use of medical information exchanged from one site to another to improve a patient's clinical health status, which is what Joe was talking about, where it used to be site to site, and now the waivers come and pretty much it's game on. Whatever device you want to use, whatever platform that you're using, I'm sure will get tightened up as we kind of begin to come out of this, and telemedicine becomes more of the norm, even within O&P. And so consequently, we look at telemedicine here as a subset of telehealth, and that it is referring solely to the remote provision of healthcare services and education using telecommunications. I'm going to just quickly go kind of through who, what, where, when, why, just to give a quick background. I think the who of this is anyone who has a valid and established patient healthcare provider relationship and has a device that is supported by technology can execute a telemedicine engagement. Whether you've been referred to by a physician for an appointment, you've received a fax with an RX, you're doing a patient outreach to check in to see how they're doing, or the patient has reached out to you independently, or you've been referred to by an insurance company like a workers' comp. We're not using telemedicine or telehealth to solicit patients because obviously we're bound by all the Medicare guidelines and the HIPAA guidelines regarding all of this. So it's not a marketing tool. It is a clinical vehicle for delivering patient care. Obviously, the what is technology platforms, smartphones, tablets, laptops, a desktop. But one of the things that I think everyone needs to begin to consider and look at with a keen eye is to choose a platform that is HIPAA compliant and make sure that that platform has a really solid business associate agreement in place that really meets the HIPAA guidelines that you run your company by and that we are obligated to engage with. And for our company, we've chosen something called Go to Connect. It's a platform that we use for our voice over IP. It's run on like GoToMeeting, Go to Connect, and LogMe, and they're all one company. And they had a really solid BAA. We've got that in place, and we are moving forward with that as a tool. Obviously, during this waiver, there's still the opportunity for all of us to use like Facebook and Zoom and all the others, because the waiver is allowing that. But as you begin to put a strategy in place for full implementation, which I'm sure we all will use when you start to realize the efficiency benefits of this type of modality, I think you'll quickly want to make sure you're on a platform that's HIPAA compliant. And when you can execute a telemedicine appointment is any time because any time that the appointment doesn't require a physical exam, right? Joe went through all those obligations for when we need to be face-to-face and what is physical. But what is more important is where. I think you need to recognize the HIPAA compliance around this, and your telemedicine appointment should be in a private room where you can close the door and ensure privacy between you and the patient. Probably not at a practitioner desk where there's lots of movement and people can walk behind, or your kitchen table, or in a public forum. You want to be in a private location and make sure that you establish that with the patient when you're speaking to them, so that they know that you are protecting their privacy. And obviously why we got into this is because of this pandemic that we're going through and the waiver that's here and the need to continue to see patients, and the importance of connecting with them when they're home. We want to be more efficient, and these appointments are more efficient than a 30 or 40-minute appointment. You might be able to accomplish it in 15. I've spoken to a lot of physicians where they're like, I never was going to do this, and now it's the best thing I've ever done. I'm so efficient. I can see so many more patients and give better care that this is going to be part of my daily practice. And I think we're going to see that in O&P. It obviously benefits patients who are having difficulty with transportation. If they have an issue and they need you to see a wound or check out like a red spot where a strap might be bothering them, you could do it very quickly and perhaps give them some advice over the phone. It benefits patients with low mobility and obviously those with a compromised immune system. But let's get to the how, because I think that's what everybody's looking at. And, a telemedicine appointment can be scheduled just like any other regular office visit. You create the link, you email it to the patient through whatever vehicle that you have set up that they've agreed to. Unless it's just a verbal, not all of them need to be video. A lot of them can be just a telephone call. And maybe it's just calling them directly on a number that they've provided. At the schedule, this is the thing I think that's really important for us to all consider, is at the time that is scheduled, the practitioner, they're in a private room, the door is closed, once a connection's been made, we want to make sure that you as a practitioner get consent from the patient for the appointment via this modality. So you want to put a script together that everyone follows, that is something to the lines of, before we begin our conversation, I must inform you that we are using GoToConnect or whatever platform you're on. It's a third-party application. It's being used for this telemedicine appointment. Third-party applications potentially induce privacy risk, and we've taken all the reasonable steps to protect your privacy to limit those risks. And ask them, will you give consent to use GoToConnect or whatever your tool is for today's appointment? And make sure you get a verbal acknowledgement from them. And then you also need to make sure that you document that you've done that in your notes. If a patient refuses the consent at that point to the type of application that you're using, you'll have to end the appointment, and you may not discuss any medical information with them at that point. And then maybe you'll hang up and just get on the phone, or figure out how to reschedule that appointment on a platform that they're more comfortable with. Otherwise, if you've gotten their consent to proceed, the appointment should proceed with no difficulty, and let the patient, just as if they were in your office, ask the questions, maybe look at some visual of the area that is affected that you're looking at for treatment. If they're showing you something on the screen, you might want to take a screenshot of it. We use AOPA, and when we take screenshots in AOPA, it automatically goes right into the chart, but you want to make sure that whatever tool you're using to take a screenshot, that image is not stored on that device permanently. You want to move it to wherever you're putting it in their electronic medical record, and then delete it from that device, because again, that is a HIPAA privacy issue. And then at the conclusion of the appointment, you want to make sure that you not only document it per whatever your normal protocols are, but that you end it by saying that this was conducted via a telemedicine appointment, because you want to have that statement in your documentation for future reference. So that's a quick snapshot of how we're implementing it. We have been using telemedicine. We've been speaking to physicians that way. We've been checking in on patients on a regular basis. We've been able to do some OTS mail deliveries and then following up with patients for fit purposes. So it's really working, and it's creating efficiencies that we wouldn't. It's a silver lining in COVID. We'll leave it at that.
We do have some specific requests for you, Kathleen. There's a request, would you be willing to share the information that you've provided today? Just for everyone to know, we are recording this town hall, so it will be available. The link will be provided to everyone. You'll have a recording of this whole process, but there's a few people that would like the information you've shared
Sure,
today.
I can give you the bullet points that I just went through. I'd be happy to.
Great. And we had a question about creativity and taking care of P&O patients during the COVID pandemic, which I think you addressed some of the how in that. Have you found any other interesting or novel ways that you all are using telehealth ability?
I don't know. I don't know that I would say anything is novel. I think some of the things we have learned with amputees are, if you're going to be getting a visual, it's best to have them use a smartphone as opposed to a tablet or like a computer, because it's very awkward to get around like the area. Perhaps you might not get good perspective. I think you might have to do some training for some of your patients so they get used to using the devices and get used to seeing you. And I think we all have to get used to seeing ourselves on these, on these videos, because not everyone is comfortable being looked at in a video setting, and you want to assure comfort for your patients. But I've actually, because we've had to furlough some of our administrative staff, I've had the opportunity, again, another silver lining, to be answering the phone when the patients are calling and talking about it, setting up a telemed appointment, and they're like, oh, I've been doing that with our doctors. It's not a problem. We're used to it. We got this thing down, and it's happening, and it's here, and I don't think it's going to leave.
I agree. Well, one of the things I want to share while in reference to O&P and telehealth are some of the resources that AOPA has. So I'll be sharing my screen here just to show you all. If you're on the AOPA website at aopanet.org, in order to access our COVID-19 responses and resources, you can go over here into the right-hand corner and click on resources. And that first option is the COVID-19 Response and Resource Center that AOPA has put together. Additionally, we just launched a telemedicine telehealth page, and this webpage is on the AOPA co-op, and it's dedicated to this topic. So it's actually in our trending topics section of the co-op. It includes the telehealth specific resources, and it also has a brief description of AOPA's telehealth strategy. And this is what I want to talk with you all about today, and share some inside information about the work that we're doing at AOPA to help support you. In addition to building educational resources and assisting members in navigating current rules and regulations, we are working with our alliance partners to secure a pathway for O&P providers to bill for telemedicine services. And those include assessments and troubleshooting, patient education, and consultations that are outside of that 90-day framework that's already included in the HCPCS code reimbursement. And really, the COVID-19 pandemic has underscored this long existing need for recognition of the services that you all provide, in addition to those devices. And to that end, AOPA has been working with our congressional champions to include Provision 2A of the O&P Medicare Patient-Centered Care Act, which is the provision that would statutorily distinguish O&P from DME. And we're working to get that into any future possible COVID-related relief bill. That has not come to fruition yet, but certainly an effort and one that we've asked you all to advocate for. It's one we shared during our policy forum I think 2 weeks ago now. And so we'll be sharing the alliance letter once the final draft of that is approved and all of our sister organizations sign on to that. So that will also be available here on the telehealth page on the co-op. So those are just a few of the resources that are available to you to support you. And again, that strategy that we that I just discussed is broad. We recognize that it's hard to build out a platform and implement new practices in your facility when those things are not reimbursed. There's no operational motivation for some small organizations and large to really build a robust system for this type of care when it is not reimbursed. And so this pandemic has really underscored the need for action on it, and our sister organizations agree. And again, with the educational piece, we're learning so much from you all. Your feedback is tremendous to help us assess where we need to go next and how we can build out appropriate support system for you all in practice every day. So please continue to let us know, what you need from us and how we can better serve you as AOPA members. Okay, so I'm gonna go to our questions now and see if we have any additional ones. Yes, thank you, Mark. Your comment on pushing legislation right now, it really is has been very easy to educate members of Congress. It's about O&P services, and Justin is actually on the back end here. He's here with us, and he has these conversations regularly with folks on the Hill about that telehealth. They were asked, oh, what can we do for you all regarding telehealth? And he would say, well, actually, O&P can provide care via telehealth, and has been for years, but there is no real way to bill for those services. And so it's been an opportunity to educate. Justin, did you want to add anything?
Yeah, happy to. Thanks, Ashley, and thanks for the question. So, we worked to get a separation of O&P from DME into the last bill that was passed by the House last week, their COVID-4 bill. We were ultimately unsuccessful, but honestly, in a way that is okay, because that bill is not going to get very far in the Senate. The Senate has not committed to what they're going to do next in terms of COVID legislation. But suffice to say, they are not taking up that House bill. So we're currently working with the Senate to see if we can work out something with whatever that next bill is going to be. However, given that we don't expect that bill until mid-June at the earliest, certainly not until after Memorial Day, we are working with Congressman Mike Thompson, who I think some folks know is one of the main sponsors of the Medicare O&P Patient-Centered Care Act. He's also chair of the Congressional Telehealth Caucus. And given that this is an issue that's very close to him, he is going to work with the Telehealth Caucus to circulate a congressional sign-on letter, which will be ultimately sent to Secretary Azar and Administrator Verma, requesting that they come up with some sort of solution during this time to allow billing for telehealth. It's not going to be as in-depth as the alliance letter that Ashley mentioned, but this will put additional congressional pressure on them to do something during this period. So that's what we're working on currently. In fact, hot off the presses, we've heard that all four of our original sponsors of the bill are going to sign that letter. And like I said, Congressman Thompson is bringing that to the Telehealth Caucus for more signatures. We'll also have a letter coming from the Senate as well. So you'll hear more about this in the coming days.
Thank you, Justin. And we'll share all of those resources on the co-op on that page that's dedicated to telehealth. One of the things I didn't share, and I meant to mention this earlier when we were asking questions to Joe, we have found that there are some very specific state requirements and regulations that differ from state to state. And so we are right now resourcing links to all of the state regulations. So where there's a state regulation that might apply, it's also going to be linked on your state's co-op page. So we're trying to build these resources so they're all in one place and easily accessible for you all as we walk through this. And we might find some stumbling blocks. I know that we have received reports back from a couple of members that say, no, we have a state rule that says, only a licensed professional can provide telehealth this very specific way. And so, people are having to follow different regulations in each state. So we will be sharing that information and links to those regulations on each state's page. Okay, I'm going to check to see if we have questions. All right. Well, since there are no additional questions about AOPA's approach right now and the work that we're doing, I'm going to ask Dr. Grover to join us and share some information about the role of telehealth in the continuum of care and the importance of working with physicians to make sure that our patients are receiving the care that they need, and how telehealth is the role of telehealth in that. And we're going to open up a poll question right to start off. Dr. Grover, are you with us?
Ashley, I'm right here.
Wonderful. So are you, the poll question to all of the attendees, are you currently utilizing peer-to-peer telehealth to work with referring or physiatrists? We've got votes coming in. Wow, this is interesting. Yep. So this is this is the other way. Right? So we've got the exact same number, the exact same ratio, but less people using. So only 38% are using peer-to-peer telehealth, and I think that is an opportunity that we might want to be expanding on. And I'm going to ask Dr. Grover to share some thoughts on that.
Well, thank you very much for having me on this call. It's been very interesting for me to listen to all the work that is being done in the background to try and make sure that folks with limb loss and other folks with orthotic needs get all the care that they need. And so I really want to start by thanking everybody on this call for all the work that they do. I know there is not enough recognition of the clinical aspect and the clinical value that orthotists and prosthetists actually bring to the field in general. So I think that legislation that I just heard about, where I think that there was some progress made, I think that is great, and I think that is something that is worth pursuing, and I think you will find a lot of support in general from other folks as well in this partnership, in this team. As far as working with limb loss is concerned, what we have found is that the continuum of care, my specific specialty being limb loss. So I work a lot more with prosthetists. I do a little bit of work with orthotics and orthotic devices, but the bulk of it is prosthetic devices. So what we have found is that there is a disruption in the continuum. And when we think about the continuum for folks with limb loss, we really can start right at the time when they have the surgery. Then they require rehabilitation for their leg to get better. Then they actually are eligible for a prosthetic device. Then they get a prosthetic device, and ultimately they are able to learn how to use it and go back in the community. I think the prosthetist role for all of these stages throughout this journey, which in the best case scenario is about 3 months, maybe a little bit shorter, but oftentimes is much longer, is vital. And this has been completely disrupted by the pandemic because people are falling through the cracks at each of these stages, especially with us not being able to provide the same level of close monitoring that we could before. So telehealth has become a very vital piece of this of a strategy to be able to take care of these folks. And I think the role of the prosthetist along with the physiatrist together is probably a very important collaboration. There are 2 ways to think about this, or 2 care settings. The first one is inpatient. So in the inpatient setting, as we recognize, whether it is post-surgery or it's a rehab hospital, visitors are limited. I think on a case-by-case basis across the country, orthotists and prosthetists being able to actually visit with the patient is gradually opening up. In case this were not possible, I think it is still reasonable for a facility to be able to get an orthotist or a prosthetist on call over the video, maybe have a combined visit with the patient or at least with the physiatrist to evaluate and prescribe orthotic and prosthetic devices. For the outpatient setting, there are two scenarios. One is that the patient actually comes to a clinic and the prosthetist can be remote or the prosthetist can be in person. Now, so when we talk about everybody being in person, obviously that is still not happening robustly around the country. So telehealth again becomes important. And there are two models here. The first model is that the patient actually stays at home. And there is sort of a conference call, I guess you could call it, between the prosthetist, the patient, and the physician if the electronic medical record system and the institution allows it. So that is subject to institutional regulations. Second model is that the patient actually goes to visit the prosthetist, and the prosthetist is able to help with the physical exam and able to help with discussing the componentry, which would have happened in routine with the physician. And the physician is remote in this case. So in both ways, telehealth is really helpful. And currently at my institution, they're allowing telehealth not only for old patients, which is what they had started with, or established patients, but even with new appointments. So we are still testing this out. We are still in the early phases, but I know at some other places around the country, this has already been happening more robustly.
Great, thank you. You know, we talked a little bit about the fact that O&P is considered an essential health business, and yet we've received requests from members or notification from members that they're getting stopped at the hospital doors or at the skilled nursing facility doors, and the front desk will say, "Oh, you know, just give me the device and I'll take it to, you know, to the physician." And the reality is that that's not the way the provision of O&P care works. The prosthetist or orthotist needs to see the patient in many cases to deliver the device. And so we're navigating some of these operational challenges because O&P providers aren't able to see patients. And one of those areas has been facilities. So we had a question about working with skilled nursing facilities and specific ways that we might be able to incorporate telehealth pre-submitted, and I'd love to get the group's input on that question if anyone has anything they'd like to share. Either Kathleen or Joe or Dr. Grover, anyone that wants to jump in.
Actually, I think it's important. You know, that when O&P providers are serving and are patients in an inpatient facility, whether it's a skilled nursing facility, whether it's a hospital, wherever it is, that they have certain obligations where they are providing service. Yes, they are providing service facility as final responsibility for. So there has to be some understanding in working with your partners in the inpatient realm, at the skilled nursing facility realm, at the hospital realm, and making sure that you are balancing the need for access to patients with the need for patients to have safety and to control potential exposure. So, you know, one of the strategies and one of the ways to do this effectively is to make sure that the lines of communication remain open with the administrators of those facilities to make sure they understand what your infection control protocols are, what your protocols that you put in place for your business, so that you can provide them with relative confidence that you are going to maximize your access to their patients without causing unnecessary exposure to the patients by entering that facility. So it's really another example of where there needs to be partnership as opposed to demands or conflict. And that goes in all aspects of life, from the kindergarten playground to the healthcare arena. I mean, there's so much more that can be accomplished through partnership than there can be through conflict, and it's a lesson that we learn every day, and you know, is beneficial to anybody who is involved in that situation. So just my thoughts on that.
Thank you, Joe. I know that Dr. Grover, you mentioned this idea that the collaborative opportunities that exist, you know, where it's kind of a teleconference for a patient and multiple providers. And I do know that the Council for Medical Specialty Societies has looked into, or is had a conference specifically about the potential for reimbursement in that area. So reimbursement for peer-to-peer or multi care provider opportunities. And I do know that is being researched. I know physical therapists have been part of that discussion, as well as physiatry. So I do think that telehealth, I think we all think that telehealth is here to stay. I think that there are a lot of opportunities for us to incorporate it into practice, and also to advocate for reimbursement. But it does bring some new opportunities in being more integrated in the healthcare team, as Dr. Grover described. Okay, I'm gonna.
So the one thing I would add to that I think is really, really vital to stress upon is that right now telemedicine is allowed in the context of the pandemic. I think it is really vital for everyone, all disciplines in healthcare, to try and make sure that a lot of these changes are here to stay. Because it does, as you mentioned, it does offer all of us the opportunity to not only continue to provide care, but maybe provide care better, maybe provide care across geographic boundaries, across distances, reduces the overall infrastructure that is needed. So it may actually end up having a great impact in terms of reducing healthcare costs as well. And then ultimately, it may actually lead to creation of an absolutely new system from a healthcare perspective that ultimately works to integrate everybody, working together along with the patient to actually improve patient outcomes.
Thank you, Dr. Grover. All right, so I'm going to check in on our questions to see if we have any new submissions. So we have a question here about advice on how to advocate. And obviously, AOPA sends out a lot of call to actions, and Justin described the letter that he's working both with the House and Senate to get sent over, you know, with the telehealth caucus, I believe is what he referred to. What we are going to be doing is I guess calling on you all to share your stories, to build sort of a robust feedback loop so that we know what's going on in practice, what are the challenges, what are the issues that you're facing, so that we can build out these advocacy campaigns to appropriately match what you're actually experiencing. So many of AOPA's staff attended the Amputee Coalition's their advocacy forum. So it's like our policy forum. It was held a few weeks before ours, or the week before ours actually. And during their advocacy forum, we were watching the chat function, and so many patients were responding that they really wanted to be able to see their prosthetist via telehealth, and that they thought that their prosthetist should be paid for that. And it's amazing sometimes when you think our patients, this is why we do it, right? It really should be the patient at the center of all of this. And so that patient-centered approach can really help in terms of advocacy. So we asked the Amputee Coalition, would they be willing to partner with us on something to advocate for it, and they said they would. And so we're excited to be partnering with them. And again, the Alliance will be sending a letter. So that's all of the O&P sister organizations on behalf of you all, on behalf of the profession, we'll be sending a sign-on letter to CMS. And we have a meeting coming up this summer with Administrator Seema Verma, where we certainly will be bringing up the distinguishing O&P from DME and its importance in pushing a lot of these efforts forward. So a lot of long-term goals incorporated in there, but in terms of advocating for paid telemedicine, I think that's that's something that we're working on right now, and hope to have something ready for you all to do associated with that. Justin, anything I missed? Anything we need to add there?
No, I think you hit it all, but I really appreciate everybody who's willing to get involved, because we can't do this by ourselves. We need the voices of our members and your patients out there helping to advocate on all of this stuff. So please do open those emails and send those alerts. We'll probably have one going this week to get that Dear Colleague letter circulating as well. So thank you for your involvement.
Thanks, Justin.
If I may add one more thing, I would like to say that from the ACRM perspective, the Limb Restoration Rehab Networking Group, you can count on us as well.
Great, thank you, Dr. Grover. That's important. It's been really beneficial also for us to be attending those meetings. Thank you so much for the invitation, and I've learned so much just listening to the different disciplines discuss telehealth and ways that that's working for all the disciplines. So thank you.
Certainly.
We have a couple more questions that just came in, so I'm gonna ask those. From a manufacturer standpoint, how are O&P facilities looking to have reps of CFABs interact with clinicians via telecommunications? Wow, that's a really that's a great question, and I certainly one we should explore at AOPA. Rather than having the reps visit the offices, it seems like that is a great way, a great use for telehealth. Also, are there any electronic resources needed for manufacturers? So for those of you who are on the call from our manufacturer members, we would love for you to share any of the resources that you all have put together. If you have a mechanism to connect with your customers, our members, our patient care facility members, via telehealth or telecommunications that you'd like to share, we're happy to post that on our member-to-member section of the co-op. It's a place where all of AOPA members can share free resources with each other, and we're happy to share any resources you have for us there. Okay, I think that's all of the questions we have. We're always around. I'll kick it back to Eve.
Thanks, Ashley. I want to thank first our speakers, Dr. Grover, Kathleen, DeLawrence, and Ashley and Joe. And Justin also chimed in there a few times. We really appreciate the information, and I really appreciate some of the silver linings that, in particular, that Kathleen and Dr. Grover were able to share with us today. We also want to thank you all for attending and really for submitting your questions. Anything that you still have questions on, we are always here. We can be reached by email, we can be reached by phone, and we're always happy to answer your questions. And again, we really appreciate everyone's participation and want to wish everyone a great evening. Thanks, everyone.